subscribe now and press the bell icon. Never miss an update.
Welcome to Health Live at Seniors Today. We are here this March 11th evening, and our guest doctor today is Dr. Radhika Banka. Before I welcome her, let me just introduce her first. Dr. Radhika Banka is a senior pulmonologist at the Hinduja Hospital, Mumbai. After her MBBS and PhD in respiratory medicine, she did an MRCP in the UK and is a fellow in pleural medicine at the Oxford Pleural Unit in the UK. After completing her postgraduate residency at the Hinduja Hospital, Dr. Banka moved to the UK, where she worked at the Norfolk and Norwich University Hospitals, followed by the Oxford Pleural University, which I mentioned. And then she relocated to India. During her stint in the UK, she gained immense experience in multidisciplinary management of common respiratory illnesses, including asthma, COPD, ILD, pneumonia, lung cancer, and tuberculosis. She has super specialized in the field of respiratory intervention and pleural diseases. She has gained skills in thoracic ultrasound and has been certified with Level 2 Royal College of Radiology Thoracic Ultrasound Competence. She has gained expertise for ambulatory medicine of pleural effusion with indwelling pleural catheters, an area which is still in its nascent phases in India. She has several publications, 16 international publications and 4 national publications were attended. And today we have invited her to speak about pleural effusion and lung fibrosis. Welcome to Health Live at Seniors Today.
Thanks a lot, Pradyum, for the very kind introduction, and thank you for having me over here. It's just fantastic to see the initiative that Seniors Today has started, and I'm honored and privileged to be sharing a little bit about pleural effusions and lung fibrosis today. So many thanks.
So before you start with your the presentation that you requested you for, and then of course to address queries of people, I just before you came in, you mentioned that you were just meeting one of your last patients this evening, and tell me, is your business, is your field, given all the pollution levels that exist in this country, and especially in a city like Mumbai, which was otherwise not known for being a very polluted city, has that increased considerably?
Absolutely. I mean, it has increased many folds. So the air quality has been poor of Mumbai since October of 2022. So the normal AQI in, say in 2020, 2021, which was around, say, 90 and 100, has shot up to more than 250 to 400 in most parts of the city. Now, there have been a lot of factors for that. It's a lot of it is because of the construction, the massive amount of construction going on in the city, whether that is with the metro constructions or of residential constructions, and also the air, so that there was a difference in the change in even the air winds this time. So there was a lot of stagnation of air in and around Mumbai, which contributed to this. Now, and this has massively led to a lot of respiratory problems, and that's because when the air is polluted, you have a lot of foreign particles in the air, right? So whether you have small amounts of hydrocarbons or you have unwanted particles in the air, which are basically foreign to our breathing tubes. So when we inhale that polluted air, all these particles which are there, which are not native to our breathing tubes, suddenly the lung gets very inflamed because of these particles, which leads to like a chronic cough. And surprisingly, what we're seeing is that even people with absolutely normal, healthy lungs have had such a persistent cough, which is just refuses to budge for like 3 to 4 weeks. So it's been a massive health hazard. And to be honest, I don't think we've come up with any solution for this. So coming and visiting specialists is not a global health, or it's not a is not a solution that we've got on a larger scale. I think they have to look into measures like probably like decreasing the number of hours of construction a day, using better material, or I don't know, some other sort of like protective gears have to be in place to prevent this from worsening, because this is going to have a massive impact if we don't act on it now. So not only is it going to affect uh, adults, but even growing children, are going to most likely land up with weaker lungs as they grow older. So this is definitely an area of concern for all of us.
Doctor, let me ask you a question. You are at the Hinduja Hospital, where once again there's a fair amount of road construction, metro construction happening, not very far from where you are. Uh,
Yeah.
yeah, so what I was saying was that you are at Hinduja Hospital, not very far from where metro construction is happening. How does Dr. Radhika Banka take care of her lungs?
So I am 24/7 in a mask, and that too a N95 mask. So as we speak, it's right here. So I think masking really makes a big difference. I know it's not feasible, it's not convenient for a lot of people, um, but in India, so before this whole pollution, tuberculosis was another big risk factor for us doctors especially. So I think COVID has taught us the importance of masking. So I even when patients are coming in with this kind of a chronic cough because of the bad air or poor air quality, I think masking is extremely important. The other thing is just taking care of a good lifestyle. So making sure you're eating healthy, you're sleeping on time, you're not smoking, you're not uh, drinking a lot of alcohol. So just having a good healthy lifestyle so that your immunity is fairly good. I think that's extremely important. And third, I think just avoiding, so at certain times of the day the AQI is the worst. So generally we've seen it's pretty bad at say 5-6 in the morning, especially when the temperatures dip. So you kind of want to avoid that kind of a time. I mean, a lot of people go running and walking and for their daily routine exercise that day at that time of the hour. But if with such a poor air quality, you probably want to avoid that time and go when the air quality is slightly better. But I don't think we have a clear cut answer in terms of what you do. I think is just maintaining a good healthy lifestyle, and masking, I think, are the two most important things right now.
Okay. Doctor, before you go get into your presentation, one last question about what you just spoke. When masks were part of our lives until recently, and I still carry a mask with me wherever I go. But specifically for pollution, what is the kind of mask that you would recommend? I know you showed me the N95, but
Yeah.
what happened is that through this COVID period, there was N95, K95, P95, hundred thousands of them. So which is the mask to wear for pollution?
So
But the way I see it is that, in a city like Mumbai, in a city like Pune, wherever, construction is happening everywhere.
yeah, absolutely.
So, what do you going to do?
So personally, so I think, I mean, there is data to show that N95s are the best masks to wear, um, followed by surgical mask, which is just like the plain, the blue mask that we get, and followed by that is the face covering. So face coverings tend to have the least amount of protection, but they're absolutely better than nothing. So in order of preference, it's N95 versus after followed by surgical, followed by face coverings. But I know it's very difficult to get used to the N95. It's very claustrophobic. I mean, a lot of people find it very claustrophobic. But if you can get used to it, then I think that's the mask to go to.
Great. So, N95 days are here again. If for those of you who are living in cities like Mumbai, where there's just so much of construction happening, and Mumbai, Pune, I guess it's metro construction is happening everywhere, perhaps, except for say in a city like Delhi, which already has a lot of metros. So that's something that we have to live with, I guess, for the next 4 years, and that's the price of infrastructure development that perhaps one is required to pay. Anyway, Doctor, let's get on to the presentation which we have for today on pleural effusion and lung fibrosis. We've had several respiratory physicians in the past, but we've never really tackled this specific issue. So over to you, Doctor, for your presentation. And then those of you who have questions specifically on this, please put in your question in the Q&A tab with your age and gender, as we always request you, that Dr. Banka could give a more considered reply. Remember, the first priority to the question which I will give Dr. Banka is on these two topics, and the rest later, if we have the time, we will discuss about other respiratory issues. Over to you, Dr. Banka.
Great. Thanks a lot, Pradyum. So I'm just going to be talking about these two conditions today, something called pleural effusion and pulmonary fibrosis.
Could you speak a little louder? Sorry, it's again.
Yeah, sorry. So today I'm going to be talking about pleural effusion and pulmonary fibrosis. So a lot of y'all might not have even heard of these diseases, and some of y'all might have heard of them. So we're going to start with very fundamental basics in terms of what these diseases do and what exactly happens in these diseases. And I'm very happy to take any questions at the end of it. So what is a pleural effusion? So let's start off with what does this exactly mean? So just if you can see in this diagram, so we have our lungs. So we have a right lung, the left lung, the heart in the middle. And just outside our lungs, we have two linings. So you see this one is the blue lining and the other one is this red lining. And these two linings are known as the pleural linings. Now, generally in a healthy individual, these two linings almost rub against each other. And as you see, there's just like 3 or 4 ml of fluid, as you see on the left side of the lung here. So, it's a healthy lung. The two linings of the two pleural linings adhere to each other. Now, pleural effusion is basically accumulation of fluid in between these two linings of the lung. So this is not fluid within the lung. This is fluid in the cavity or in the linings outside the lung. Now, as you see, when there's fluid here, it can compress the underlying lung. And that's what, can produce symptoms, which we will just see in a minute. Now, what is the normal function of this pleural space? I told you a lot about these two linings. To be honest, it's a redundant space, actually. We don't even need this space, but it's just there. And it's almost like a storehouse. So, when there is, for any reason, when the body starts producing extra fluid, it gets stored in this pleural cavity. And surprisingly, this pleural cavity can hold liters of fluid. So it can hold at least up to like 5 to 6 liters of fluid. I know that's quite surprising, but that's how compressible our lungs are. So the reason I've put this picture up is, so these are elephants, and elephants don't have the pleural space. So, when they try to do an autopsy on the lungs of elephant, that's in 1681, sorry, they found that the elephants didn't have this pleural space at all. And this is very interesting. So this is the picture of a bison. And the way to actually kill a bison is just to take a spear or a spade and just poke it on one side of the chest cavity. And why is that so? So, when you pierce one of the pleural cavities here, it causes a lot of accumulation of air in this pleural space. And because the cavities in bisons are communicating, so the two pleural cavities in bisons are communicating. So even if you just pierce them on one side, because of the communication, air gets filled in both these cavities, which causes compression of the lung, and the bison dies. So this was actually the way to actually hunt bisons in the older times. In humans, our pleural spaces, the one on the right and the one on the left, are completely different. So they don't communicate with each other. So this is just a little bit of history and anecdotes about the pleural space. So what happens when you get a pleural effusion? So, what are the symptoms? How do you present? So very rarely you might not have any symptoms, and it might just be picked up accidentally when you've got a chest x-ray done for some other reason. Most commonly it presents with chest pain. Now, the kind of chest pain that you get because of an effusion is something called pleuritic chest pain. And that's very typical. So it's very sharp. It's worse on when you take a deep breath in, and it's worse on coughing. So it's very different to a muscular pain, which tends to be more dull aching. This is almost like a pricking sort of a pain. You might get breathless, shortness of breath. And as we just spoke about, because, when there's a lot of fluid, it can compress your lungs, which can make you feel breathless. you might get a cough, and that's typically a dry cough that you get. There's not much of phlegm or expectoration with that. You might feel just very tired, and you can have fever. So if you've got this fluid filled up because of an infection or some other causes, you might even run some temperature. So pleural effusions are very common. So this is what an effusion looks like on a chest x-ray. So just to give you a brief idea, this is your right lung, that's your left lung. The middle part is all normal, which is your heart, and this black part is your lung. So as you see on the left side, you can see the lung all the way nice. So that's your diaphragm, which is your main muscle of breathing. And this is what happens when you have an effusion. So this becomes all obscured or opaque, and that's because the lung has collapsed because of the fluid surrounding it. So it just gives a very opaque picture on an X-ray. So that's how you diagnose an effusion on chest X-ray. So it's got a high incidence, so almost 3,000 cases per million per year. And as we've spoken, it causes a lot of symptoms, and it can be a diagnostic challenge as well. So effusions can be bilateral. So as you see here, so you can see an effusion on both sides of the lung. So you see there's some fluid here, there's some fluid here, or it can be unilateral, meaning just on one side. Now, when it's unilateral versus when it's bilateral, the causes are completely different. So when it's unilateral, you think more of sort of an infection. So in our country, the most common cause of pleural effusion actually, or unilateral one, is tuberculosis. Second thing would be secondary to pneumonia. So when you get a pneumonia, there can be some fluid around the lining of the lung, which can also get infected. Third is cancer. So cancers can spread and cause fluid to be filled out. So now that can be either lung cancer, or it can be cancers from other parts of the body. What we do need to know is that when a patient gets cancer and if fluid has filled in this pleural space, we already know that the cancer is at an advanced stage. There are a lot of other causes, such as certain drugs can cause it, certain autoimmune conditions, but and obviously, if you do get an effusion, your physician would take a history for all of this. What about bilateral effusion? So we spoke now. So they tend to be more because if you've got heart failure, kidney failure, liver failure, all of these conditions generally cause fluid around both sides of the lung. Now, how do you investigate a pleural effusion? So the most common is a chest X-ray. So we've just seen what X-ray findings look like because of an effusion. The second is a CT scan. So your physician or your doctor might ask for a CT scan, and this is what effusions look like. So you can have this gray area is where what the fluid looks like, and this, it can be in pockets or it can be pretty free flowing, which we can get some more idea about. The third is an ultrasound of the chest, and that is actually the most sensitive way to look for a pleural fluid. And this is what just an ultrasound looks like for your interest. So the black part is all the fluid that we have, and this is just the collapsed lung that we can see because of the fluid. The next thing, so we've seen an effusion on the chest X-ray or the CT scan or the ultrasound chest. Now, what do you do next? Is important that you remove a bit of the fluid or the entire fluid, but not all patients, with an effusion need aspiration. So it all depends on, how symptomatic you are. So if you are mildly symptomatic and you've got some bilateral effusions, which we know are secondary to a heart failure, so your doctor might not want to even put in a needle and get that fluid out. But if you have a large effusion just on one side of your lung, then your doctor might want to remove most of it to help with your symptoms and also to find out what the cause of the effusion is. So as a rule, all unilateral effusions should be aspirated because it helps to identify the cause of the effusion and also relieve the symptoms. So once we remove fluid, it can look like this. So this is the most common color that we see. So it's a little yellowish color that we see, very characteristic of tuberculosis. Then you can get a little bloody fluid. So it's quite red in color. And this can give us some idea. This can be seen in certain types of cancers. And this is actually pus that can be aspirated because of an infection. So just having some idea, looking at the color of the fluid that is aspirated can also give us some information about what's the cause of the effusion. And how is pleural fluid aspirated? So it's a fairly straightforward procedure. it's done as an outpatient basis. It's done under local anesthesia, so you're not given any sedation. This is typically how you generally be asked to sit for it. So, you rest your arms ahead, and the operator will be doing something at the back. It's always done under ultrasound guidance, because the ultrasound tells us how much of fluid is there, and where to exactly put in the needle. And at one time, up to a maximum of 1.5 liters of the fluid can be drained. The reason we don't drain more than that is because when your lung starts expanding because of the fluid being removed, that can, if it expands too suddenly, it can cause a lot of chest pain and coughing. And it's actually a very safe procedure. So, few side effects or complications that can happen is you might get a bit of pain when the fluid is being removed. Very rarely there can be some amount of bleeding. But on the whole, it's a very safe procedure, done as an outpatient basis, done in the local anesthetic. So if you ever need to get this procedure done, don't be afraid of the fact that, as I said, it's a very safe procedure. And this is what the needle looks like. So, once we put in the needle, that's all your fluid that we see on an ultrasound. And we can actually see where the needle is coming in the fluid as well. Now, very rarely it's that the fluid might not give us an answer. So, we've drained the fluid, we've sent it for all our tests, but we're still not sure what the cause of the fluid is. And that's when your doctor might refer you to get some biopsies done. Now, where are the biopsies done? So the biopsies are done from the lining of the lung or the pleura, one of the pleural surfaces. And this is generally done under sedation or general anesthesia. So, this you'll be made to lie down on one side where the fluid is there, you'll be given sedation, so you're completely knocked off. And then they, the surgeon or the physician would put in a small little endoscope sort of a scope, and then look inside the pleural cavity. So this is what, just out of interest, to show what a pleural cavity looks like. So this is a very normal looking pleural cavity. What's pulsating at 6 p.m. was the lung. So this is the lung. And this is just the pleural surface, which looks very normal when you inspect it. And now, just to show you what a very abnormal lung looks like. So this is the lung that we see. And now if you can just see a lot of nodules here, so which we didn't see in the other part. So these are the very abnormal areas, which is very characteristic for cancer. So if your fluid, once I've aspirated fluid, if I don't get an answer from the fluid, it doesn't show me any cancer cells, then the next step that I might want to do is put in a small little scope and look into exactly the chest wall cavity. Can the fluid come back again once I remove it? Yes. So certain conditions can cause recurrence of pleural fluid. So the most common is cancer. Tuberculous pleural effusions don't generally tend to come back because, once the fluid is removed, you treat it with TB medications, or if you've got an infection in the pleural space, you treat it with antibiotics and it gets better. But with cancer, if the cancer is not under control, the cancer cells can continue multiplying in the pleural space and cause these effusions to recur. And obviously any effusion because of heart, kidney, or liver failure can recur, because it's not like the liver failure or the kidney failure is going to get better. So that can cause recurrent pleural fluid accumulation as well. Now, what happens if this fluid recurs? So, obviously there is the option of constantly putting in the needle and removing it every few days. But now we do have more sophisticated options where, we put in a chest tube. So you put in a chest tube in this space, and you connect it to a little bag or a bottle, which just allows the fluid to drain over, say, a couple of days. And then once all the fluid is out, we can actually do something called pleurodesis, where you try to stick the two linings of the lung so that the fluid doesn't come back again. And that can be done using certain chemicals. The most common chemical we actually use is something called talcum powder. So, but obviously that's sterile. So that just causes the two linings of the lung to stick to each other. And as I said, it's a redundant space. It's absolutely got no function in our body. So even if you land up sticking the two linings of the lung, it's not going to impact in any way. So this is one way what can be done in case of there is a continuous refilling of fluid. The second option that we have is something called an indwelling pleural catheter, where the doctor might want to put in a semi-permanent catheter just below the skin. And this remains on the side of your chest wall, and this can remain in for weeks or even months. And the fluid can be drained using these suction kind of bottles, 2 or 3 times a week, depending on how quickly you are filling up fluid. Now, these kind of procedures are not very commonly done, but obviously, if somebody has recurrent effusions, meaning, every time you tap the fluid or every time you remove the fluid and the fluid comes back again, then you do have these kind of options for the fluid. So, what do I want to tell you from a pleural effusion is, so don't ignore the symptoms of chest pain and breathlessness. So not everything is related to the heart. Pleural infections, especially if you've got an episode of pneumonia and you see that there's being fluid being formed around it, that requires urgent actioning. And that's because it's very important to remove all the infected fluid from that space. Because if you don't remove that infected fluid from that space, it's just going to increase the infection. And particularly in elderly, it's very important to act swiftly, because it's got a very high mortality of almost 30% at the end of 1 year. So pleural infection in elderly definitely needs early treatment to prevent complications. If you're diagnosed with a pleural effusion, you may be needed to undergo further investigations, including removal of the pleural fluid. And this is primarily to A, relieve your symptoms, and B, very important to even know the underlying cause of pleural effusion. Right. So now we'll move on to the second part of my talk, which is lung fibrosis. So lung fibrosis, pulmonary fibrosis is the same thing. So it's a fairly common respiratory disorder that we see, and this is lung fibrosis generally tends to affect the elderly. So where we talk about asthma being more common in children and young adults, lung fibrosis generally tends to affect the elderly. So what exactly is lung fibrosis? So lung fibrosis is basically where a healthy lung tissue gets replaced with scarred tissue. So it's almost like when we get burnt, there's a little bit of a scar that is formed on our skin. So similar kind of scarring when it happens in the lung is called lung fibrosis. And so lung fibrosis is a very layman term for fibrosis. The more scientific or the more generic term for this is something called interstitial lung disease, which is an umbrella term for this. So what exactly happens in lung fibrosis? So as we know, so our breathing tubes divide, and the end of the breathing tubes, there are these alveolar sacs, which are basically like bunches of grapes. And this is where, the whole diffusion of gases happens. So this is where, oxygen is taken into the body and carbon dioxide is thrown out from the body. So this is your alveolar sacs, or the bunch of grapes that I just spoke about. Now, what happens in interstitial lung disease is that the lining around these alveoli, they get extremely thick. Okay, so when they get extremely thick, these alveolar spaces decrease in size, and it is at this septum, or it is at this area, is when your actual diffusion of your gases is happening, is when you actually take in oxygen and throw out carbon dioxide. But because this has gotten so thick, the diffusion is impaired, meaning you don't get enough oxygen, you can't throw out the carbon dioxide, and that's when you get all the symptoms of lung fibrosis. Now, what causes lung fibrosis? So, unfortunately, in almost 65% of the cases, we don't know why it happens. So that's why we call it something called idiopathic, where we don't know what's the reason. It can be because of certain exposures in an environment. So pigeon droppings are a big source of causing lung fibrosis. And that's just because certain individuals are very sensitive to these kind of pigeon droppings, which when inhaled can cause fibrosis in the lungs. Certain kind of farmings can also cause lung fibrosis, little less relevant in our urban setting. Certain medications can cause, so certain drugs like nitrofurantoin, which is a antibiotic very commonly given for a urinary tract infection. Corduron is a medication used for irregular heartbeats, or methotrexate, which are certain medications used for treating rheumatoid arthritis. So these conditions can also cause lung fibrosis. Then there can be conditions such as some certain autoimmune conditions, such as rheumatoid arthritis, which tend to affect various parts of the body. So they primarily affect the joints, but they can also affect the lungs. And then obviously, if there is a family history of interstitial lung disease or lung fibrosis, that can tend to run in families. So there is a genetic component as well to these to lung fibrosis. Now, what are the symptoms of lung fibrosis? So, lung fibrosis generally tends to be a more chronic illness. So, it's not like you're going to develop symptoms in a few minutes or a few hours or a few days. So, this tends to have a more indolent course over a few weeks to months. The most common symptom that you will have is dry cough, followed by shortness of breath, and particularly you will realize it will be more on exertion. So it's only in the late stages of lung fibrosis that you are breathless on rest, but primarily it will just be progressive. So you realize, say, 6 months back, I could walk 100 meters of distance, but now after 6 months, I can walk only 50 meters of distance, because when I walk 50 meters, I get very breathless. So it's a very progressive shortness of breath, particularly on exertion, that we notice. Next, you can have is weight loss. So especially with the idiopathic variety, weight loss is a common symptom of lung fibrosis. Sometimes you can present with fever as well with lung fibrosis, and very rarely you can also get other symptoms such as a rash. You might get some joint pains, especially the small joints of your hands. You can get some dry eyes, you can get some dry mouth. And obviously your doctor would ask you for all of these kind of symptoms as well. Now, how do you diagnose lung fibrosis? So chest X-ray. So chest X-ray is actually a very crude way of looking for lung fibrosis, and it's not the investigation of choice for lung fibrosis. CT scan is the investigation of choice for lung fibrosis. And this is what a normal, so on the left side of the screen, you see a very normal looking CT scan. That's your right lung, that's your left lung. In the middle is the heart. The little white spots that you see are all blood vessels. Now, a fibrotic lung looks something like this. So you see very abnormally looking lung. So you have certain cysts that are formed, like certain kind of holes in the lung, with certain, these blood vessels that I just spoke about tend to get more dilated. And these are all certain characteristics of lung fibrosis that we see on CT scan. Now, why is CT scan important? So not only is it important for diagnosis, because different types of lung fibrosis can have different types of patterns on CT scan, but it's also very important to monitor this disease. So as I said, so lung fibrosis tends to be a more of a chronic illness, and you need to be on medications for a long period of time. So your physician would want to get repeated CT scans, say, every 12 months or so, to see whether the disease is getting better, is getting worse, or has it remained the same. So CT scans form a very important part of diagnosing and monitoring lung fibrosis. The next thing is something called pulmonary function tests, which some of you all might have even done this in the past. So this is basically a blowing, this is also called a spirometry, which basically blows into a machine. And that objectively gives us what the lung capacity is. So is your lung capacity 60% of what it should be, 70%, 80%, 90%? And this again is helpful for diagnosing whether you have lung fibrosis, and also again for monitoring. So to assess, whether the treatment that has been given to you, has it led to any improvement in your lung function? So you might be asked to repeat these tests every, say, 6 to 9 months by your physician. The next thing your doctor might ask you to do is something called a 6-minute walk test. As the name suggests, you just walk for 6 minutes, and what we're looking for at the end of 6 minutes is how much distance have you walked, B, what is your oxygen saturation before and after the test, meaning has there been any drop in your oxygen levels after walking for 6 minutes, and what has your heart rate been? Has your heart rate increased or decreased? And if it has increased, how much has it increased? And subjectively, how breathless you feel. So again, this is a good test for regular monitoring every 6 months, and it's a very non-invasive test. You just are made to walk for 6 minutes. So it's a very good test for monitoring lung fibrosis. And certain blood tests may be asked for. So your physician might want to get some blood tests done to look for any other causes of lung fibrosis as we spoke about, apart from the idiopathic variety. Now, the next thing is the treatment of lung fibrosis. So, chances that, if your lung fibrosis is very minimal, and you're not very symptomatic, again, just picked up when a scan was done for some other reason, you can just apply a wait and watch policy if you have stable and minimal symptoms. It's not like that all patients with lung fibrosis progress, nor do we know how quickly will one person progress as compared to the other. So that's why, as I said, this disease requires very close monitoring with CT scans and lung function. The next thing, most common medications used for this are steroids. So you might be put on steroids for a long period of time. We all get scared thinking of steroids, but at this stage, steroids are more important to prevent the further damage to your lungs. And again, this has to be done under the supervision of your doctor. The next thing is something called antifibrotic. So there have been two new medications that have come out, and this has primarily revolutionized the treatment of lung fibrosis over the past 10 years. So say 10 to 12 years back, if you got lung fibrosis, it was almost a very grave situation because we didn't really have anything to offer to the patients. But now with the advent of two new medications, there's definitely been a much higher improvement in survival in terms of quality of life with use of these medications. As we spoke about with lung fibrosis, your oxygen levels can dip, and that's because the oxygen diffusion across the alveolar membrane is impaired. So you might need supplemental oxygen therapy, and that supplemental oxygen therapy can be either in the form of a concentrator or it can be portable oxygen devices. The other thing that can be used for lung fibrosis is something called pulmonary rehabilitation, which is basically, in simple words, exercise for the lungs. And there are special physiotherapists who are dedicated for this, who can help you build up your lung capacity. And last but not the least, lung transplant is an option for lung fibrosis. And if you do fit the age, the criteria, those are certain options that are available in India as well now. So regarding lung fibrosis, the treatment, so the take-home messages would be, so it's a chronic illness, you need to be under the care of a respiratory specialist. So this disease is beyond the capacity of a general physician. You cannot be, ad hoc see your physician once in a while. You have to be under the care of a respiratory physician who you do need to see every 3 to 6 months. You need regular monitoring with lung function tests, with CT scans. There has to be monitoring of side effects of medications, because some of these medications, including steroids, can have a lot of side effects. Antifibrotics can be difficult to tolerate. So this requires monitoring. And there can be progression of disease and of symptoms even despite being on medication. So this requires a lot of very holistic approach, with your physician, with your GP, with your, with the palliative team. So palliative team are doctors who specialize in keeping the patient, who specialize to keep the patient's symptoms under control. And this, with patients with advanced lung fibrosis, there has to be in terms of clarity in terms of what the treatment goals would be. So whether you should even take them to hospital, whether you should put them on the ventilator. So these are discussions that need to be done when, the lung fibrosis is at an advanced stage. Right. So yeah, that's about it. So I'm going to stop sharing my screen now. I'm very happy to take any questions.
Thank you very much. Thank you very much. A very detailed presentation, and the questions that we've got are fairly general, but I will take a couple of questions which are important. Doctor, does one get pleural effusion if you sleep immediately after a meal, and if the mattress is not in good shape?
So pleural effusion, so nothing, absolutely nothing. So it's got nothing to do with beds, mattresses, position of sleep, nothing at all.
All right. So the person has replied, sent a thing. But what about water getting into the lungs if if you're not sleeping properly?
So as I said, this is pleural effusion is all water around the lung. It is not in the lung.
Right.
So the only reason when you get water in the lung is when your heart pumping is reduced. So when you've got cardiac failure. So when your heart pumping is reduced, the extra water cannot be pumped out, cannot be thrown out in the form of urine. That's when you can get some fluid in the lungs. So cardiac failure is the only cause for getting fluid in the lungs. So it's got absolutely nothing to do with what you eat, where you sleep, how you sleep, what you do. Obviously, what you eat has a certain extent, can have certain effects on cardiac failure very indirectly. I mean, if you're diabetic, you can develop cardiac failure, but there's no direct correlation between
Right.
food and pleural effusions or anything.
We have a question from Manava Narayan Rao. Is what precaution preventive action to take to avoid fibrosis or pneumonia? This person is 83, COPD for a peculiar face allergy on steroid for more than 10 years. Prednisone.
Right. So that's a really good question. So I think first and foremost, I think I've stressed upon it enough, is a good healthy lifestyle, making sure you're eating well, sleeping well, you're giving a bit of physical exercise during the day, because there's a lot of evidence now to show that just a healthy lifestyle people with a healthy lifestyle tend to have a better immune system than people who don't. Second, at the age of 83, vaccination is extremely important. So, taking the flu vaccine yearly and taking your pneumonia vaccine every 5 years is important. So, although, these vaccines don't guarantee that you might not get flu or you might not get pneumonia, but the chances of you getting severe flu, leading to hospitalization, or severe pneumonia leading to hospitalization is much reduced, similar to what we saw with the COVID vaccines. So vaccination is the second most important thing that I would recommend in this age. And thirdly, you need to assess in terms of the need for the steroids. So, and obviously look at the side effect profile of the steroids. So making sure, your bones are intact. So making sure you not develop osteoporosis. Diabetes needs to be, checked when you're on long-term steroids. And most importantly, do you still need that dose of steroids for some allergy, face allergy, or whether that can be stopped, but that has to be discussed with your dermatologist.
Right. Thank you. We have a question from Shivaraman Srinivasan. He says, if at night phlegm production in sleeping in AC is too much, is it infection or fibrosis? No chest pain, probably COPD, he says. And how does one develop an immunity to lung issues, lung problems?
So coming to the first part of it, so lung fibrosis typically does not present with the characteristic cough is a very dry cough. So you don't really get a lot of phlegm production, and specifically nocturnal, night cough with phlegm goes more in favor of asthma or COPD or something. So I would look for those causes first rather than thinking of lung fibrosis. But obviously all of this needs to be evaluated by a GP or by your specialist. There's no one way. There are certain kind of fibrosis which can have a bit of phlegm, so you can't make, it's not a absolute 0 or 100%. The second part of the question was how do you improve the immunity of the lungs? Is that correct?
Right.
Yeah, so again, I think it just comes down to the basic phenomenon of exercising, good nutrition, good sleep, making sure you don't have any of the comorbidities, blood pressure, diabetes. Of course, smoking is very important. So, making sure you don't smoke at all. And even environmental exposure and occupational exposure. So if you are in a job where, you're working in factories where you have a lot of exposure to fumes and dust, and chemicals, at least make sure that you're wearing a N95 mask when you're in that environment, because that definitely can affect the lungs over a period of time. But in terms of supplements, if a lot of people ask me, what supplement should I take? And I'm not a big fan of supplements, because I think if you just have a good diet and good lifestyle, you can get most of your supplements, unless, of course, like if you're a vegetarian, vitamin B12 is going to be low. If you've got if you pretty much indoors, your vitamin D is going to be low. So those kind of supplements, can be taken additionally, but I don't think there are any supplements per se to boost your lungs.
Right. We have a question from Mr. Lakshminarayan, who's 68. He says he's been walking 7 kilometers every day, and it used to be non-stop 5 kilometers in about 45 minutes. Of late, he says that he needs to take a break after 1 kilometer as it gets a bit tight for him. Is there anything that you would advise him?
So if somebody, I mean, I firstly congratulate him for walking 7 kilometers, and especially then walking at a space of 9 kilometers an hour, which is at 9 minutes per kilometer, which is fantastic. And suddenly, if he's getting breathless after 1 kilometer, he definitely needs to be assessed by a physician. So now here there could be two causes. So it could be the heart, it could be the lungs. Now both of that needs to be looked into, obviously with tests and proper history and all of that. So I would definitely recommend seeing a doctor.
Right. Doctor, there are quite a few questions which are fairly general in nature. Okay, there's a question from an anonymous attendee who says, I'm on medication for CML. Pleural effusion was caused due to side effect of the medication. So under control now, what precautions or what should I keep in mind to keep it under control, and how can I improve the immunity of the lungs?
Yeah, so CML, so certain medications used to treat CML like the dasatinib, imatinib, are, so as I said, certain drugs cause effusion. So these imatinib, dasatinib are known to cause effusions. Now this requires a close liaison with your hematologist, because at times you need to decrease the dose of these medications. You might have to give some additional steroids to control the effusion, or at times you might have to just change the medication completely. There's nothing per se in terms of what you can do as an individual to not have these effusions. I mean, there's nothing specific. Obviously, the usual, have a good lifestyle, no smoking, but nothing specifically to prevent these effusions, especially in CML induced because of certain medications.
Right. So, Doctor, there is a question from Mr. Bharat Mehta, who's 66. There's a question from Mr. Narendra Shah, who's 71. This all seem to be asking a question as to how does one keep lungs healthy, and specifically for senior citizens, what precautions should one take to keep it healthy? Some of it you already answered, but is there just a couple of things that they should definitely be doing, or definite no-nos? You mentioned smoking, you mentioned healthy diet, etc. But are there a couple of magic immediate quick fix?
I don't think there's magic, but definitely for everybody above the age of 50 should take the flu vaccine. Everybody above the age of 50 with lung problems like known asthma, known COPD, known fibrosis, known if you had pneumonia, should take the pneumonia vaccine. So vaccination is an absolute essential part. The second part is also
sorry, just to interrupt. Now, the vaccination, you said one is the influenza vaccination and the other is the pneumonia vaccination. Now, can both of these things be taken together? Influenza vaccination, I remember people have said that it's a better time to take it is in the around the monsoons in India, in Mumbai.
Yeah, so you're quite right. So you take the flu vaccine in around June every year, because there are strains that are released, which are estimated to be more prevalent for that year, and the strains are different for the northern hemisphere and the southern hemisphere. So we follow the southern hemisphere strains, and the new vaccines are then made, having antibodies or having those antigens, which are prevalent for that year. So the best time to take the flu vaccine is around May, June of each year. And that's a yearly vaccine. And the reason it's a yearly vaccine is because the strains change every year. So that's the flu vaccine. The pneumonia vaccine is generally a 2-schedule vaccine. So the first vaccine is just taken once in a lifetime. And then the second vaccine is taken either 8 weeks later or 1 year later, depending on what your comorbidities are. And the second vaccine needs to be repeated every 5 years. Now, in the US, they have just one pneumonia vaccine that's not available in India yet. but there are chances that this might come up in India as well in the next year or so. So then we just have one pneumonia vaccine, and once you've taken it, you're done.
Right. We have a question from Mr. Mukesh N, who says, I have RA plus fibrosis. I have mucus coming from my nose regularly. Why is it happening?
So RA, so yeah, again, we spoke about autoimmune conditions can cause fibrosis. So that's what Mr. Mukesh has. So the mucus from the nose is unrelated to this. So this is more of some sort of allergic rhinitis, sort of a picture if you're getting mucus from your nose. So generally unrelated to ILD or rheumatoid arthritis.
Right. And Mr. Dinesh Paliwal asks, is it can one get the pneumonia vaccine in various places in Mumbai and other cities?
Yeah. So it's available over most of the pharmacies. And in fact, your local GP can give it to you. So you don't even need to come to any of the big hospitals to get the vaccine, actually. Just get a prescription from a doctor, go to a pharmacy, pick up the vaccine and get it administered by your GP.
Right. Doctor, we have a question from and Nadi's influenza. This is Malcolm Montero who's asked, with the influenza jabs, yearly influenza jabs, does this jab cover influenza A, B, C, and D? Which is the best time you've said is June. And yeah, so do these cover A, B, C, and D?
So mostly they cover A and B because those are the ones which are generally tend to cause more severe illnesses. So most of them, so it's mostly the A and B strains that are covered.
Right. Doctor, there are a couple of questions about masks and how it's difficult to wear a mask, etc. So is an N95 mask that you recommended okay when I go for a brisk 30-minute walk? Would it not result in inhaling more carbon dioxide as compared to oxygen?
No.
And somebody else is saying that the mask gives him a breathless condition.
Yeah, so I mean, the first thing I said was very difficult to get used to these masks. So if you can't get used to it, completely understandable. So in that sense, don't wear a N95, at least wear a surgical. So nothing is better, something is better than nothing. So if you can't wear N95, go for some other sort of a mask. In terms of N95 and walking, and so there is no theory of carbon dioxide levels increasing. So that's all a myth, because of these masks. But yes, you can feel more breathless wearing a mask and exercising. That's just because your body needs more oxygen, when you're exercising, and that might be a little difficult to get with the N95. But if you can, then that's great. But there's definitely no rise in CO2.
Right. There is Mr. Bharat Shah who says fluid accumulation in lungs led to breathing trouble and heart attack. Happened twice to him.
I'm sorry to hear that.
Sorry?
I'm sorry to hear that, actually.
No, he hasn't given any question. So, so doctor, what about exercises? As in, people who are not able to go out for whatever reason. What are few basic exercises that you would perhaps recommend?
So I think it depends on overall physique, how fit and well they are, and what comorbidities do they have, and whether they have any musculoskeletal problems like joint pains and all of that. So, but in general, assuming you're a fairly fit and healthy elderly person, then just cardio, so just walking in the house at least for like 15 to 20 minutes minimum, and then doing a bit of exercises for strengthening your muscles of the hands and the legs. So if you can do a bit of squats, if you can just do basic exercises of raising your hands above your head, and a small amount of weights, actually just even a 0.5 or 1 kilo weight to just keep your muscle mass going. Because what happens as you grow older, we start losing muscle mass more rapidly than what we do as young, as what we do when we're younger. So just keeping the muscles going with just muscle exercises or even a small amount of weight is very good. And then if you do have respiratory problems, then just diaphragmatic breathing, meaning taking a deep breath in, holding your breath, breathing out slowly, doing straw exercises wherein, or the spirometer where you have the balls, the three balls, you take a deep breath in and try to hold them as high as you can, after a period of time, you see all the three balls going up. So those kind of exercises would be the best thing to do at home because these are simple, don't require much of equipment either.
Doctor, we've far overshot time. Thank you for an amazing session. We've answered quite a few questions as well. Thank you very much for taking your time off on a Saturday evening and for answering all our questions. We will be back once again next Saturday for another session of Health Live at Seniors Today. In the meantime, thank you, Dr. Banka, for this session. And let's all hope that we have better air and a healthier tomorrow.
Absolutely. Thank you. It was my pleasure to be here. And I would like to thank Seniors Today for having me here, actually. Thanks a lot. Thanks a lot.
Thank you very much. Thank you.
You're welcome. Bye.
Subscribe now and press the bell icon. Never miss an update.